So I have this 45-year-old gentleman who presents for a cardiac checkup. He has a negative past medical history, no cardiac history, no family history of cardiac disease. He's asymptomatic from the cardiac standpoint. He has a good exercise tolerance, and in fact, he exercises 5 times per week. He's a chronic smoker, and physical examination is unremarkable. He does not have any history of hypertension, and his blood pressure is normal. This is his lipid profile. So I want to ask you if anybody wants to volunteer and tell me whether this patient, based on the 2013 guidelines, ACC, AHA guidelines, will require a statin. Who thinks this patient would require a statin by raising their hands? Okay, and who thinks this patient does not require a statin? So a little bit, okay. And who did not vote? I need to see many more hands because most of you did not vote. Okay. We're half awake, so I'm going to try to keep you awake for the rest of this talk. The guidelines, what do they tell us? And let's see where this patient fits. There are 4 statin benefit groups as per the guideline. One of them is the classic clinical atherosclerotic cardiovascular disease, which is defined as acute coronary syndrome or a history of MI or unstable angina, peripheral vascular disease, TIA. So this is the classic requirement for a statin. The other group is the LDL more than 190 if you're over 21 years of age. The third group is if you're a diabetic age 40 to 75. The fourth group is if you have none of the 3 above, but you have what's called a 10-year atherosclerotic cardiovascular disease risk of more than 7.5%, which means if the patient has more than a 7.5% risk of developing a cardiac event, death or MI, within the next 10 years. This is from a calculator that you're all familiar with that I'm going to show you and go over with in a minute. So why not continue to treat on target? Forever we've been trying to treat to target less than 100 for LDL or less than 70. That's because current randomized clinical trials data do not indicate what the target should be. So we've always gone by targets, even though targets were just cutoffs that were not proven scientifically. And then there is an unknown magnitude of additional reduction of risk with one target compared to another. So why is 70 better than 100? Why is 100 better than 120? And there are unknown rate of additional adverse events. So to get to target, let's say to 70, like we used to do, we used to most of the time rely on multi-drug treatment. The statin enough, even at high doses, most of the time was not enough. So what is the risk of going on those multi-drug treatment, risk versus benefit? So all of this made the guideline authors move away from targets and rely on randomized clinical trials and rely on intensity of statin therapy. So this is a busy slide, but I want to take you through it because it's quite important. First of all, before you start anything, you have to really emphasize the importance of healthy lifestyle, diet, exercise, and so on and so forth. But those are the groups that I've discussed with you before. If you're, first of all, we're not going to give statin therapy for people under 21 unless they have very specific conditions. But over 21, if any patient over 21 have a clinical event, then that patient should be on statin. If their age equal or less than 75, normally it's the high intensity statin, versus if the age is more than 75, then you rely on moderate intensity statin. What does that mean? High versus low versus moderate is on this table here. I don't try to remember them. I usually just use 1 or 2 of the statin groups. But for example, in the high intensity, atorvastatin 40 to 80 or rosuvastatin 20 to 40, and so on and so forth. The idea is the high intensity normally will drop your LDL by more than 50%. The moderate intensity will drop your LDL by approximately 30 to 50%, and the low intensity by about 30%. So going back to that chart, if you have on the second category any patient with an LDL of more than 190, after you can try diet, of course, and losing weight and exercise, if that patient remains over 190, then automatically that patient is in the group of high intensity statin requirement. If the patient is a diabetic, either type 1 or type 2, then would require moderate intensity statin unless that patient has an atherosclerotic cardiovascular disease risk of more than 7.5%. So this is that fourth category, which is the atherosclerotic cardiovascular disease risk. How do you calculate that? You calculate that by going to the calculator, okay? And I keep it actually on my iPhone. I have it always here, and in fact, I like to show the patient the application, and some of my patients are interested and downloaded it actually. It's very easy to download, and you simply do the calculation, and we're going to do some of that calculation in just a minute. But if the atherosclerotic cardiovascular disease risk is more than 7.5%, then that patient needs to be treated with a moderate or high intensity statin. If it's between 5 and 7.5, then also you can discuss with the patient treating with a moderate intensity statin. For sure, in my practice, I rely on the more than 7.5%, and I treat all my patients who are more than 7.5% unless there is a contraindication with the statin. This is provided, of course, they don't belong to the other categories. So I'm going to basically, but here there is this box right down there that sort of is a bit permissive. In other words, it allows you, despite what you see and despite what you calculate, to discuss this with the patient and consider other things, although they don't tell you what to do with those other things. Like if you have a calcium score, or if you have a CRP that's elevated, or if you have a premature history of coronary artery disease in the family. So these type of things we know as cardiologists are important. They're not factored in the guidelines, but there is that box that tells you think about them without telling you how to think about them. So there is that risk calculator that I told you about, and it may be difficult to see the writing, but I'm sure all the cardiologists in this room are familiar with it. You put the gender, the age, the race, white, African American, or other. If the patient is diabetic, hypertensive, or smoker, and you put the systolic blood pressure, the total cholesterol, and the HDL. It takes you 30 seconds to plug these things in, and our patient who has this profile, you plug him in, and what do you get? You get a risk score of 10.6%. So if we go by the guidelines, which we should, of course, why do we have guidelines? Then that patient needs to be on statin. 10.6 is pretty high, and you can go moderate or high intensity. I normally go with a moderate intensity statin. So I prescribed a medication, a statin, for that patient, and of course had a conversation with him. He was a bit surprised. He's fit, he's healthy, he's not obese, he exercises on a regular basis, but of course he smokes and he has a low HDL. So I explained all that to him, and I told him, you know, as per the guidelines, and again I pulled my my application and told him how we derived this, and told him you have to end up on a statin, gave him the prescription, and after patient education sent him home. Now, because he belongs to that category. Now, let's take that same patient and let's think of him if he was not a smoker. So now, instead of this box down there ticked as yes, if he was a no, then with the same parameters, his risk drops to 4%. Then he does not need to be treated. That same patient now, who's 45, I changed the age to 55. So I left everything else the same. If he was not a smoker, not hypertensive, not diabetic, but with a low HDL and age 55, even though he's not a smoker, he gets to get treated. Now, let's say that I change the HDL to 50. So now I have a perfect picture patient with no smoking, no diabetes, no hypertension, 50 HDL, total cholesterol 193. So everything is fine, systolic blood pressure 130. Then it's 5.5. Okay, he's sort of on the borderline for the moderate intensity or low intensity statin. But I want to take it a step further. This picture perfect person, okay, who's very healthy, as per all these parameters, I change now the age to 59. And everything else, HDL is 50 and everything else is fine. He's 7.9. He needs to be treated. So I'm bringing that up to your attention only because this is where the guidelines take us. So you're going to say, for example, you know, a 70-year-old with a perfect picture of health, by this calculator you're going to treat. Well, the answer, if you look carefully in the guideline, there is this paragraph which I think is important for me to read to you. Some worry that a person aged 70 years without other risk factors will receive statin treatment on the basis of age alone. The estimated 10-year risk is still more than 7.5%, a risk threshold for which a reduction in atherosclerotic cardiovascular disease risk events has been demonstrated in randomized clinical trials. Most atherosclerotic cardiovascular disease events occur after age 70, giving individuals more than 70 years of age the greatest potential for absolute risk reduction. In other words, what we're trying to say, we're all going to die of something. And when we're all over 70, the most common cause is going to be atherosclerotic cardiovascular disease event. And giving protection as per the randomized clinical trials may help. So I'm bringing this to your attention so that these guidelines do not allow us to think anymore in terms of LDL level alone. There is that atherosclerotic cardiovascular disease risk. Despite a picture-perfect lipid profile, based on age, you may still end up on a statin therapy. So that was that patient. Now, of course, if I have this picture-perfect person, 59, who's a female, I click female instead of male, it goes down to 3.2%. So females have a leeway of several years. They're always better and ahead of us. Now, this patient, who's actually a real patient from my clinic, 3 weeks ago I saw him. So this is not something that I invented. In fact, when I saw him, with my discussions with him when he was a smoker, I told him at the beginning, I gave him a paper for lipid profile to do, a request for lipid profile, which he did, and I gave him a calcium score to do. And maybe Dr. Mallah will tell me later on if I did the right thing or not by ordering a calcium score. But I did, and the guidelines actually will allow you to do that. And the calcium score, he chose to do it 2 weeks later after I gave him the statin therapy. The calcium score was 0. And again, this is a real patient. So now what do I do with the information? Well, nothing, because the guidelines still tell me treat. They're not telling me that if the calcium score is 0, you don't treat. But there is data that came out this month in, I think this was JACC intervention. I think it was JACC, yeah. 10-year coronary heart disease risk using coronary artery calcium and traditional risk factors. This is the MESA, multi-ethnic study of atherosclerosis, basically indicating that there was this algorithm that was developed based on a study of 6,000 patients with a calcium score, and they came up with their own score. Now that score is as follows, as you see here. It has more indicators than the regular modified Framingham score. It has history of atherosclerotic, it has family history and family history of heart disease. And it has one more thing, which is the calcium score, as you see here. Now you plug my patient in there and you calculate the 10-year risk score, it tells you that classically that patient would have received a 5.8% score on this one, but with a calcium score of 0, it's 3.1%. So it cuts it almost in half. In fact, another article in the same journal from the MESA study also tells you that the absence of calcium score reclassifies approximately 1/2 of candidates as not eligible for statin therapy. So the 2013 guidelines actually estimated that maybe 13 million people are going to be treated with statins more than the previous guidelines would allow. Now with this, we're going to say that maybe half of the patients treated by the new guidelines, if they have a calcium score of 0, will not need to be treated. And this is an example from the study of a 70-year-old who's hypertensive, but everything else is fine. His score would be 9.3%, but if the calcium score is 0, it comes down to 3.1%. So I think these are the type of things that eventually will have to get into the guidelines and guide us what to do. For now, my patient, based on the guideline, is still going to be on statin. So now let me tell you a couple of words to shift gears on the PCSK9 inhibitors. Now, the PCSK9 inhibitors have become a little bit more interesting because of their data. But first of all, let's understand what they do. The LDL is cleaned up from the circulation by complexing with the LDL receptor on the membrane of the liver. This gets recycled, the LDL enters the liver, and then there is a dissociation because of a low pH, and the LDL receptor is going to recycle to the surface to engulf more LDLs. This is a continuous process. The LDL receptor keeps working that way about 100 and 150 times. Each LDL receptor is going to do that job before it gets eaten up itself. Now there is this regulator mechanism, one of which is the PCSK9, which basically complexes with this receptor and then makes the whole thing lyse by the lysosomes. So now the LDL receptor is going to also lyse, and you will have less available LDL receptors, and that's why the PCSK9 is a regulator, so that it will reduce the effect of the LDL receptor. If you inhibit it, then you allow for more clearance of LDL. And there are many studies that have occurred over time. I'm going to need more of the 2 minutes that we lost at the beginning. So now that we have that this receptor, the PCSK9, was discovered in 2003. There was an identification of gain of function mutation as a cause of autosomal dominant hypercholesterolemia. So the role of the PCSK9 was identified around 2005, and then the structure was also unveiled, and the inhibitor, a monoclonal antibody, was also synthesized, and then the studies were initiated. There were several studies that you've heard of over the past 4 or 5 years, actually. And I'm going to talk to you very briefly about 2 of them that were just released in the New England Journal of Medicine. So evolocumab is one of those 2 medications, which is a monoclonal antibody against PCSK9. What it shows is that there is a dramatic 60% reduction in LDL over and above the classic treatment that the patient has been on, a 60% reduction. And in fact, this reduction was translated into a drop in the cumulative incidence of cardiovascular events over a period of 1 year. And then most adverse events in terms of side effects occurred with similar frequency in the two groups, although the neurocognitive events were reported more frequently in the treatment group. What are the neurocognitive events? This medication and the next one I'm going to discuss, it's mainly some memory loss. So it's very subjective, but there was a difference between this and placebo. How is it given? It's given as injections. Now you can see that there is monthly injection and biweekly injections. In this study, it was a biweekly injections, and both of them give a dramatic drop, but with not a very big difference between the biweekly and the monthly. But the biweekly is 200 milligrams and the monthly is 400 milligrams. So the next drug is the alirocumab, also an antibody, a monoclonal antibody, also is dramatic 60% drop. And as compared with placebo, there is also a little bit higher incidence of injection site reaction compared to placebo, a little bit more myalgia, neurocognitive events, and some non-specific ophthalmologic events. So it's a fairly well-tolerated drug. And in a post-hoc analysis, the rate of major adverse cardiovascular events was lower for the treatment group than the placebo group. And the difference was small, but it made statistical significance. So these are very attractive drugs. So far, we have to wait on long-term studies. So for example, there is a long-term 5-year study of 18,000 patients that's underway. So you need to know the effect of these type of medications long-term and study the benefit and side effect, and also study which patient population it would be more which patients would be more eligible for this type of treatment. Thank you very much.